Thank you very much. Good afternoon, everybody. Thank you for having me. As Bobbi said, my name is Paul Uhrig. I'm the Chief Administrative Officer of Surescripts. And I want to talk to you a little bit today, just briefly, about Surescripts, our history, the opioid crisis, and also, I was sitting in a little bit earlier, sort of the path of e-prescribing to interoperability, since that is such a big topic here. There we go. So, who is Surescripts? What is Surescripts? We are a network. All right? We are a health information exchange created in the United States back in 2001. And we were created for the purpose of digitizing the prescription management process. We are really the result of two companies that were created in 2001. Surescripts System was created by the pharmacy industry in Arlington, Virginia. So the two associations that represent chain and independent pharmacies created Surescripts Systems. At the exact same time, three of the largest PBMs in the country, ePrescribing's, Medco, and Caremark, created a company called RxHub, ostensibly for the same purpose. We took a slightly different directions. We were owned by pharmacies, so we were very focused on moving a prescription from the clinician to the pharmacy. RxHub was very focused on formulary and benefit information getting from a PBM to a clinician. We merged in 2008 to become the company we are today. Our purpose, essentially, is to serve the nation as the trusted and capable health information network to increase patient safety, lower costs, and increase care. So where are we today? As I mentioned, we are a network. We're not an EHR, so we're not Allscripts, we're Surescripts. All right? We're not a PBM, we're not ePrescribing's, we're Surescripts. We are what sits between everybody. And today we are connected to virtually all of the EHRs in the United States, all of the e-prescribing applications in the United States, virtually all of the pharmacies, and virtually all of the PBMs, and transact data amongst all of them. Today, we transact about 5 million prescriptions each and every day, come through our network. And last year, we processed about 14 billion clinical transactions. We may touch on a little bit more later. We've gone beyond e-prescribing to do other clinical transactions. So what's the workflow? Just to put this in context. If I have an appointment tomorrow with my physician, let's say they're using a Cerner application. In the middle of the night, that application will send a message to Surescripts requesting my medication history and my formulary and benefit information. That message will have certain demographic information about me: my name, my gender, my birth date, my address. We have a master patient index of 230 million covered lives, and we are able to identify then where my records are. We can identify who my PBM is, it's Caremark, and where I've had prescriptions dispensed, CVS, Walgreens, or an independent pharmacy. And we will return to that physician my medication history and the formulary and benefit information applicable to me. That happens in sub-second to 2 seconds. Then the next day, the clinician has this valuable information. If I need a prescription, it will be routed to the pharmacy of my choice. It's basically our core and foundational services that we provide today. So, moving on to the opioid crisis. Don't think I need to tell you all have a crisis as much as the United States does. 42,000 deaths a year, over $500 billion in economic costs every year caused by the opioid crisis. So we look at health information technology and e-prescribing from the perspective of both divergence and trying to eliminate divergence and better care. So what we talk about first is e-prescribing of controlled substances. That's just another form of e-prescribing. It's just focused on a controlled substance. The history in the United States is that until 2010, it was illegal to prescribe a controlled substance electronically. The DEA, Drug Enforcement Administration, did not allow it. They were concerned about security. They knew how to deal with paper. They could fingerprint a piece of paper. They could do handwriting analysis on a piece of paper. The DEA couldn't quite figure out how to do that for e-prescribing until about 2010, where they then issued a regulation that permits it, very focused on security, non-repudiation, so that no clinician can say, I didn't send that prescription. Over half the states, it was illegal after the DEA rule. We had to work with all of the states to make it legal in all of the 50 states as well. The process is very similar to what I described for general e-prescribing. So where are we today with respect to that? We've seen an increase in the number of controlled substances coming across the network, which in this case is a good thing. 93.1% of pharmacies are enabled. They have adapted their systems to be in compliance with the regulation. All of the EHRs have fundamentally done the same thing. But what you'll see is only 22% of prescribers in the United States are enabled for e-prescribing of controlled substances. So we have a big gap there. And what you see as the result of that gap is less e-prescribing of controlled substances. So last year, 77% of all prescriptions were sent electronically across our network. If you look at it just as controlled substances, 90% were. Did I get the right? Non-controlled, 90%. Controlled substances, only 21%. Now, why is e-prescribing controlled substances a good thing? In terms of the opioid crisis, it is more secure than the paper prescription based on how the DEA structured its regulations. So it helps prevent diversion. It helps prevent people from stealing prescription pads. So that is one of the benefits of EPCS. The second service that we offer, I've already mentioned, is medication history. This helps both prevent diversion as well as better care. I mentioned this workflow earlier. This is really just a graphic of it. Again, that message comes into us. We have a master patient index of 233 million lives. We pull the records from PBMs and pharmacies, and we deliver that consolidated record back to the clinician. Now the clinician can see perhaps if the patient is doing some doctor shopping based upon the medication history, and obviously has a much better view of the health of that patient based upon the medications that that patient is taking. Now, I want to stress this medication history is sourced from PBMs and pharmacies, so it's claims, it's cash paid across the country, all 50 states, national network. So we believe those are two very important services around e-prescribing of controlled substances. We delivered 1.5 billion medication histories last year in the United States, and that number is increasing every year. So hopefully that gives you a very quick view of the network, of the breadth of the network, how we think about the network in terms of the opioid crisis. Our motto is better actionable intelligence means healthcare, better healthcare for all. So it's not only medications, but also other message types that we support, and maybe Bobbi and I will get into that during our discussion. So with that, Bobbi, I'll turn it back over to you.
Great, thank you. So where are we now in Canada? Okay, so I thought I'd start off just by putting some of our facts and figures up for you. We have more than 600 million prescriptions dispensed annually. So just go back to that number, 5 million a day, 4 million a day, to the size of the number of transaction counts in the States. In Canada, 9% are narcotics or other controlled substances. What we found out in some of the surveys that we've done as it relates to prescribing of narcotics and controlled substances, that 39% of the time prescribers are either never notified of a patient's drug misuse or notified after the fact, after the patient has actually picked up the prescription. And 75% of the time that notification comes from the pharmacy to the prescriber. So there's definitely a need to get better surveillance and notification much upfront in the system. So now I thought we'd have some fun, but this is an alarming fact. And this was based off a recent study that we did with patients, because we always talk about this being the last mile. Lots of drug information systems out there that are collecting dispense data, but the issue we have here in Canada is no one really has a number on what was ever prescribed. So right now, one of the alarming facts when we went out and we did this survey is 40% of prescriptions are still handwritten. So think how ludicrous this is and how far behind Canada is in this space. And what was that date you gave, Paul? 2001. I always say that Canada is clearly 15 years behind everyone. I'm now going to have to correct it and say we're actually 17 years behind as we go through. But the truth of the matter is we don't have a handle on these scripts that are written and actually never filled. And so we went out and we asked people, if you got a prescription in the last year, did you get it filled? And actually this equates 2017 data, 4 million Canadians admit to losing or damaging a prescription. So here's a little bit of humor for you. 415,000 prescriptions took a spin in the wash, 140,000 were dropped in puddles, and 88,000 say they were eaten by dogs. The sad fact is the number one reason that came out in the survey of why people weren't getting their prescriptions filled was actually due to cost. And even though we have a system a public system where a lot of the costs are covered, the deductibles are still starting to pile up, and also more and more drugs are not being covered on formularies, and that was the number one reason why people weren't getting their prescriptions filled. The number two reason was because someone was feeling better. So if you equate this back to chronic conditions that someone may feel okay but still should be taking their medication, it's alarming. And again, you see the downstream effort. So if we can get better at understanding what's happening upstream as to why people aren't taking their medications and the compliance around this, it's going to do nothing but benefit the healthcare system moving forward. So the moral of the story here is that Canada needs a national e-prescribing service. Again, 17 years behind what's been going on internationally in the rest of the world. So when we took a look at this, we thought, can we take lessons learned internationally? And this is where we made a decision to try and take lessons learned from everybody else, and can we just accelerate and jump over and catch up to where they are in the US? So we made a conscious decision to start very small, to start lean, just to get the base service up and running. And then let's get the governance around creating that roadmap and the art of the possible that Paul was referring to. They've had a lot of time to get where they are, but I also want to point out it took them 7 years for the two systems to come together, for the recognition in the states, the size of the states, that they only could support one system at the end of the day, because that is truly, when we talk about interoperability, that is where everybody has to get together and all the systems have to be talking to each other, or we're going to continue to fragment the system moving forward. So we came out with our base functionality, filling a basic script, renewing a basic script, but we also added some additional functionality that we thought was going to be important, such as adding that formulary information. So if at the time of prescribing, the prescribers have access to the formularies, they can make more informed decisions. We also have a dispense notification now for the prescribers, so that if a prescription is written, the prescriber is going to be able to actually see when it was dispensed. Again, think of it for compliance and think of it for that missing piece of information, especially for those patients of concern. The last piece that we added that is vital is clinical communications, a secure clinical communication between the prescriber and the pharmacist. And right now, we've just actually launched our full functionality. We started out with a mini release, now we've gone to a full functionality, and we have great hopes in the clinical communications. So again, you saw it earlier, acts the facts. Think of what happens today. Think of the communication that happens today with faxes, phone calls, sticky notes, you name it. And we have not great hope, we know that it's going to work, but there's great functionality in what we're delivering with this moving forward. So what is the PrescribeIT difference? Well, first of all, it's pan-Canadian. And we've talked about that, the importance of how many times people have started with pilots, mini pilots, pockets, but nobody's ever been able to scale. So we came out of the gate talking about a pan-Canadian approach where we're going to leverage economies of scale, and we're going to talk about how Surescripts has a very similar model. We also are going to integrate seamlessly with EMRs and with the pharmacy management system, and you heard this throughout the day, this is key. This isn't going outside and into a portal. This is actually seamless integration for the prescriber at the point of prescribing to make it as easy as possible to send that electronic transmission and right into the pharmacy management system. So from a benefits point of view, there's no transcription, and that is one of the key safety benefits that's out there. We had to start with small functionality, as I said, and now we're at the process a year later where we're setting out our governance structures and we're bringing the stakeholders to the table, and we've set up a bunch of working groups in a whole bunch of different areas to talk about, are we going the right way? Have we got the usability right? And what is that strategic roadmap moving forward? We're also committed to providing an influence-free dispensing and prescribing environment. Why? Because we are a not-for-profit organization that's sitting in this middle space that has no commercial interest, and we have to ensure that it's a fair and level playing field for everyone, because that's the only way we're going to be able to bring people to the table. I often call us Switzerland, I sometimes call us air traffic control. That's for you, Paul. Paul missed his flight this morning, so that's a bit of a dig on my panic on, or Interact. So those are the utility-based type functionality that we're looking at. We've had a couple conversations this morning about the importance to data, the commercialization of the data. How do you protect that data? So we are also want to sit in this middle space and protect the prescription data from commercial use and make sure that the data is being used for the good of public policy. It's also, though, we want to keep the patient in mind, and this is about patient choice. So at the time of prescribing, we know that over 80% of the time a patient knows where they're going to be taking their script to. And for those times, if the prescriber says, where do you get your prescription filled, and the patient knows the prescription will be directed straight to that pharmacy, filled, much safer because it gives the pharmacist much more time to fill the script and to think about the counseling and the clinical care aspects of it. They don't know the patient, they can hold the script, same decision rights as they have today, nothing changes. But we're also building out concern for what we're calling deferred patients. If there's a concern that that script is being diverted inappropriately, or the patient doesn't know where they're actually going to pick the script up, we are going to send the script, I'm going to get the wrong terminology, excuse me, not being technical, into the cloud. We're going to receipt the patient, and the patient can go into their pharmacy of choice, and the prescription can then be downloaded into the pharmacy management system. So we are going to be building out and operating a hybrid system moving forward. So the momentum has continued. I stood here a year ago, we talked about we had just gone into Huntsville, we were all excited. So now we're live in both Alberta, in Lethbridge, and we're also live in 21 communities in Ontario. So this is past the point of being a pilot. We are actually rolling out in production and starting to scale. When you see the two numbers there, it gives you the numbers. The first number is the number that is live. So in Ontario, 91 prescribers live, but we have 431 signed user agreements ready to go, ready to be turned on. So we're filling up that funnel, and we're thinking about how we're going to scale out and start turning on both the prescribers and the pharmacies. So at this point in time, as I say, we're live in Alberta and Ontario, and I just want to call out to thank very much Alberta, who took the step and faith with us to help move this forward, and Ontario, and the users that I know are in the audience today as part of the working group who are helping us to get this right. We are in discussions with all the provinces and territories right now. So our mandate was to get 6, we're sitting at 10 right now. So a success story. I'd also like to call out our vendor engagement, because this isn't going to work unless we can bring our private sector partners to the table. And I call them partners in this respect because people have to understand that this is for the good of the whole, and we're lucky enough that we have a large number of competitors that are all coming together for the good to get this right in the Canadian market. We're also engaging the retail community, okay? And hopefully you saw our press release a couple of weeks ago with McKesson. Why McKesson is important to us, because they have the highest number of outlet counts right now, in Canada. But I just wanted to call out to our retail pharmacy partners who are taking a leadership role in this, who understands how this works because of the experience in the States, and are helping to make this a reality. So Canada, like the US, have been going through an opioid crisis. I'm not going to stand here and preach to everybody about the severity of the crisis, because we all know what that is. But an e-prescribing service is a much safer transmission of the prescription. So what we are doing right now is we are leapfrogging, at this point, the 17 years that Surescripts has taught, and catching up to where Surescripts is, who is leading the pack. And we're going to talk about what some of the states have done as far as the mandatory e-prescribing for opioids, because we know it's going to take a long time to get through some of the legislation. One of the working groups that I mentioned in our governance structure is actually a working group on opioids. They've come out with a strategy. There's 6 different streams of things that we're working on, that what can help an e-prescribing service help with the opioid crisis. Things from, can we put support evidence based at the time of prescribing? So you think of opioid guidelines, could we put them in at the time of prescribing? We know there's some dispensing around opioids as it relates to methadone and other things like that, so we're building that into the system. We're looking how our prescription feeds can help with narcotic monitoring and surveillance, and can we speed up the process and help the process there. We want to make sure that we expand the practice sites to extend to more opioid prescribers. So what does that mean? One of the vendors that you might have seen was a company called AbleSoft. Why are they important to us? They're important to us because they have the market share of EMRs for dentists. Now, dentists don't write a lot of prescriptions, but they do write a lot of opioid prescriptions. So we're trying to capture that clinical group in there. And then we're also looking then, obviously, at the data analytics and reporting. We are not building out a database, but we will be able to deliver the feeds to help again in the area of narcotic monitoring and surveillance. So where are we? So I'm going to leave this up. We have lots of information out there. If anyone wants to keep updated as to what we're doing, here are the various mechanisms. And now what I'd like to do is sit and have a fireside chat with my friend. So let's start, Paul. So Surescripts has learned a lot in the States, obviously, for the number of years to get this up and running. What do you see? Let's start with overall the key drivers of successful adoption. What would you recommend Canada do to accelerate the adoption of e-prescribing?
So, I think you're doing a lot of the things already, quite frankly, in terms of adoption. You've got a structure very much like we created. But part of the reason I think we were successful is, quite frankly, we have owners who had a vision of digitizing the e-prescribing process and created a very mission-driven organization. You know, we are for-profit, but we are not designed to and don't ever expect to act like a profit-making entity, right? It's very much like a utility, mission-driven. So I think you have a lot of those aspects. You're taking a lot of the same steps to protect sort of information. What do I mean by that? One of our tenets is neutrality. You know, you sort of spoke to patient choice of pharmacy. One of our fundamental tenets was also patient choice of pharmacy, prescriber choice of therapy. So we have rules in place that satisfy physicians and others and to make sure we're protecting that patient choice. Convening, you know, convening is such an important part of getting successful adoption. You're transforming, you know, an industry, transforming workflows that affect providers, clinicians, pharmacists, you know, how do patients interact with the system? And we used to convene everybody, and we used to put the EHRs in one room, the pharmacies in one room, and the PBMs in the other room. They all blamed each other for everything. They blamed us for everything. And then when we got them all together and they actually started talking about some of the issues, then we started getting to a point where we're solving issues through that communication. So I think a lot in terms of convening.
So one of the things I didn't mention is that you actually have agreed to sit on one of our ad hoc board committees that is bringing the stakeholder groups together. So why do that? Now, I forgot to mention, Paul's Canadian. So why do that? You don't need to come up and help Canada build out an e-prescribing service. Should, you know, I not be walking close to a window like, is Surescripts coming up?
Yeah. No, you know, we were approached, you know, many years ago, and we've been approached by other countries. We want to focus on the United States. And so that is where our focus is. I think that's another key to success, not only for us, but for you, focus. So why do this? You know, we want to share the knowledge, right? We enjoy seeing the success. We have learned a lot through our 18 years. And if we can share that and see success in other countries, that is great for us. But we're very focused on the United States. We have enough problems there to solve.
I'm just wondering, before we start talking about the opioids, if you can just talk about the role of the patient. So we've had a lot of focus today on the patient safety. It's a little different with an e-prescribing service because you're working to make the usability better for the end users. Mm-hmm. But how did you engage the patients, and how did you bring them to the table and think about your roadmap and where you're going?
So you're right. We are a business, you know, a B2C, a B2B rather. You know, we as Surescripts will never be a business to consumer. So we are supporting prescribers, clinicians, hospitals, pharmacies, and PBMs in how they interact with their patient. You know, we got a lot of feedback from patients advocates, right? So organizations, individuals who represent the patients. What are their concerns? What are their concerns about privacy? What are their concerns about security? And so that was really how we interact with that patient community. Again, it gets back to some of the fundamental tenets. Patient choice of pharmacy, prescriber choice of therapy, secure data, privacy. You talked about data and use of data. You know, I've been on panels and had people say, you are sitting on a wealth of information. And my response is, it's not my data, it's the patient's data. And so our job is to move it from one place to another for clinical care. So trust that patients have in us, that providers have in us, that's the key to success.
So as you saw by both presentations, both countries are facing challenges with the opioid crisis. So I'm just wondering if you could give us your views on how technology can help, and how is e-prescribing helping in the States?
Yeah, so you know, maybe to get a little more into the history of that, as I mentioned, e-prescribing of controlled substances, EPCS, was illegal until 2010. We worked with the DEA for about 8 years. They come at it from the perspective of law enforcement. We would give them all the arguments about how e-prescribing is better for clinical care. that didn't resonate with them, right? They are cops, they're law enforcement. So we worked with them to get that rule in place that increases the security of the systems in place, so pharmacy systems and prescriber systems. We then had to work with the states that followed the DEA rule, and it took us a number of years to get all 50 states aligned with the DEA rule to really facilitate e-prescribing of controlled substances. So we think HIT is important for many of the reasons that I spoke about and you spoke about. It is much more secure. 3 to 9% of diversion occurs by people stealing the pad off of the desk and changing the numbers, or getting a legitimate prescription. There was a pharmacist in Ohio. The patient was given a prescription for 10 pills. The patient added 3 zeros to the end of that. The pharmacist sort of figured out 10,000 pills of an opioid. That was a little bit much. But there are other stories where maybe they just add 1 zero and it becomes 100 pills. That can't happen with e-prescribing of controlled substances. So much more secure, so it helps prevent diversion. Same thing with medication history. And then there are other message types, that quite frankly also help in that communication. So a cancel transaction. Sometimes the physician wants to cancel that prescription. It can be sent electronically and securely. Sometimes the physician wants to change the prescription, the change transaction. So all of these transactions help create a more secure environment and provide information to the prescriber so they have a much better sense of the health of their patient.
So do you have any stats, just wondering actually, how much it has reduced, say double doctoring or polypharmacy? Sure. or any metrics on that?
So the other thing that we're seeing is, as I mentioned, that gap, right? Only 21 to 22% of controlled substances are being sent electronically. So why is that? As I said, all the pharmacies are enabled. Virtually all the e-prescribing applications are enabled. Surescripts has been ready for years. So there's been some pushback from the provider community. And what we hear is 2 basic reasons. One is cost. So some EHRs have charged their customers for the ability to send prescriptions, controlled substances electronically. The other big reason we hear is workflow, mainly around 2-factor authentication. So one of the things that the DEA requires is that physicians must authenticate themselves to the e-prescribing system using 2-factor authentication. So for normal e-prescribing, you can log on once in the morning and you're good for the rest of the day. For controlled substances, you have to re-authenticate yourself with virtually every prescription for a controlled substance. And again, it's that 2-factor. It's the password, and then you get a text with the code, fingerprint, whatever it may be. But when physicians only have a few minutes with patients, you change that workflow, it's a barrier. So what's happening as a result? What we're seeing in the States are mandates. That is how they are beginning to address this issue. So 15 states have now mandated e-prescribing of controlled substances. Some states have actually mandated that all drugs be e-prescribed, but 15 states have laws in place, some won't be effective for another year or 2, that mandate e-prescribing of controlled substances. Last month, the federal government got involved, and they have mandated e-prescribing of controlled substances under the Medicare program. And that'll go in effect in about 2 years. So to get to your question. So the first state that had an effective law was New York, the iStop law. That went into place, I believe it was in 2016, became effective. And we're beginning to see some data come out of New York. Now that law was broad. It was not only e-prescribing of controlled substances, it was mandatory use of a prescription drug monitoring plan and some other elements. What they have said is they have seen doctor shopping reduced by 90% based upon changed physician behavior based upon the law. They've seen the theft of paper prescriptions drop by 70%. Now, you may think, well, of course, there's fewer paper prescriptions, fewer pads, but physicians still keep pads in the case they can't e-prescribe for some reason. And New York has said that they believe they're beginning to see a drop in terms of the number of controlled substances. Not been a formal study, they're not quite sure what to attribute that to. But in terms of doctor shopping, a 90% drop. Geisinger also just came out with a great study recently about the effects of e-prescribing of controlled substances. They're seeing a drop in prescriptions of opioids, and they're also seeing a financial return. So one of the things that we all talk about in terms of interoperability is what's the business case? And so what Geisinger is seeing is a pretty significant return on their investment in EPCS. Fewer people having to work on diversion because there's less diversion. Those types of things have helped them reduce some of their costs.
Do you think the workflow went too far with the two-factor? Because, you know, we talk about adoption and barriers to adoption. On the other hand, you know, mandating of e-prescribing makes sense. But is there somewhere in this equation that it could have that the workflow just went too far, in your view?
Well, I'd say a couple of things. First off, just in terms of anything that we're doing around interoperability, we always have to be mindful. Changing the workflow is something we just have to be very sensitive to, right? Just changing how prescribers work. I would say two things. We have to make sure these systems are as secure as possible, right? It is hard to overstate the bad guys that are out there. You know, whether it is people trying to get on a network, whether it's, you know, somebody from Romania, whatever it may be, you know, it's hard to overstate. So we need these secure systems. The problem we're seeing is this law was put in place, technology is advancing, and it's advancing beyond what the law allows. So there are likely technologies around two-factor authentication and other things that would make it easier, but the law is static, it doesn't change. And so that's, you know, it comes to that age-old issue of how do laws and regulations keep up with the change in technology, but to make sure we are secure.
Great. And can you just comment on any the connection between any of the monitoring and surveillance or any of the benefits that's had from a policy perspective?
The monitoring of the prescriptions?
Yes, has it been, you know, part of the concerns people have is it's going to be punitive, right? Mm-hmm. But yet we're sitting on all this, but it could provide the feeds for this data for the public policy and the good.
Right.
So, you know, how is the data governance piece looked at? Right,
so it gets down to data governance or what can you use it for. As I mentioned, you know, we're very careful about how we use data. We are, as we get into HIPAA, we're a business associate of the covered entities. We can only use the data for the purpose that the covered entities permit. And so we're very focused merely on healthcare, on treatment, and on moving the data. But the potential benefits are really, it's stunning sometimes of the potential benefits. Just quickly, I got a phone call from the Philadelphia Department of Health. Naloxone, we all know that that's used in the opioid crisis to revive people who have OD'd. 26,000 doses have been dispensed in the United States. What's happening is pharmacies can dispense without a prescription. So a father can go and get it, so if their son is ODing, to revive them, or friends. Department of Health has now realized they have no way of knowing how often people are actually getting naloxone without a prescription and using it. The problem of ODs may be much worse than we realize because people are being revived and it's never reported. We have data that could help inform, right, that conversation with Department of Health. So, you know, we have to be mindful of the bad uses, but there are many, many good uses.
So we're winding down. Just wondering, do you have any words of wisdom for us? Have we got it right? Are we on the right path?
I think you're on the right path. And as I said, I think you're already learning from what's happening in other countries. I do think patience is key here. Hopefully you'll be able to move faster than we did because you will learn from what others have done. But we didn't get to break even until 8 years after we were formed. Right? We started 2001, our first transaction was in Rhode Island in 2003. Why Rhode Island? Because they had a policy environment that was very, that enhanced e-prescribing, that they wanted to get it done. It took us another 5 years to get to break even. Right? It took us longer to get to scale. And it's that scale that's important to drive costs down with the efficiencies with a national network. So you got to move fast, but you need to be patient because you will get there. You will get there.
Great. Well, I want to thank you for coming up and
Sure
thanking
thing.
you for sharing your words of wisdom. And I know
My pleasure.
you're going to come back for the reception.
Excellent.
And
My pleasure.
so on
Thanks
that,
for having me.
Ben, thank you.
Thank you.